coming to you live. I'm coming to you live from Bethel, Maine tonight, and very glad that you could all join us for the next hour. We're going to talk about some general topics related to fertility and infertility and general information that's worth knowing about our practice and our process. And then mostly I'm going to try to take a lot of your questions. So there's a question and answer section. If you're on the Zoom webinar, you can enter questions. And if you're on Facebook, you can enter questions there and they'll get ported over to me. I wanted to just start with a couple of thank yous. I want to thank Emily, who's our moderator tonight. She's going to be moderating the she's going to be overseeing the technical issues, but also getting stuff over from Facebook. So thanks to her. I want to thank my staff or any of my staff who are watching. And if you see any crazy questions or comments show up in the question and answer, that's probably one of them. And I also wanted to just thank any of our patients that have joined this evening. I know many of you are maybe contemplating interacting with our office or our staff, but if you're already one of our patients, that's great to see you as well, and thanks for coming. I wanted to, before we get started, I wanted to put out some very hot off the press big news that I got about an hour ago. For those of you who are familiar with the legislative issues in Maine, we have been putting a bill through the Maine state legislature to try to get infertility covered for the state of Maine. And this has been something available in Massachusetts and Rhode Island and Connecticut and other parts of New England for a while. And it just got passed in New Hampshire 2 years ago, excuse me. And we just, it's been in committee for the last, I don't know, 6 months or something. And it just got a passing vote out of the insurance committee. So it can be like canceled or vote ought to pass. So they voted ought to pass. It was a close vote, but it's moved through. So there's still some hurdles to get through and other things, but that's really exciting. Oh, somebody is in the screen here. Hi. Yeah, so that's something to keep track of and look forward to. And we'll be keeping up to date on that. There's a Facebook forum in Maine, and also if you follow Resolve New England or RNE, they'll keep posted on some of that as well. So I just wanted to start out with some general information before I start taking questions. And oh, I just got a post from Sarah saying thank you. She's 15 weeks pregnant because of me, so it's always a good start. With just some basic stuff of like who should come to see us and when should you come and what to expect when you come. So you know, this is always sort of seems like a simple question, but a lot of people are like, well, when do I, you know, who's supposed to come see a fertility doctor? And you know, it's a range of things. So in general, we see a lot of people who are trying to get pregnant and not succeeding in some way. So that's sort of the, you know, what we call infertility consult, people who have often been trying for, you know, 6 months to a year and aren't making progress, or have done some things with their, you know, gynecologist or other doctors, and then, they, you know, are struggling in some form. So that's, you know, that's a very common thing, but there's lots of other people that we work with that, you know, have very different issues and may not have infertility at all. So one of those big group is the people from the LGBTQ+ community, people who are, you know, not necessarily having any fertility issues, but need to work with us because of need for a sperm donor or an egg donor or someone to carry a pregnancy for them. So we have many people that we work with in that situation. We work with a lot of people in the trans community who are considering freezing eggs or sperm before undergoing medical or surgical procedures. So it's also a group that we're very comfortable working with. We see single women often who are looking to freeze their eggs. So sometimes people have a uncertain reproductive story lying ahead of them, and they're early to mid 30s and they want to freeze their eggs to buy some time, and that's a common thing that we do. We see people who have potentially underlying genetic issues. So you might have something that is a genetic disorder that could get passed on to your child, or you and your partner have a genetic disorder that if you both pass it on, it could affect your child. And those are people that might be able to get pregnant, but they have to use some of these more advanced fertility treatments to make embryos that we can test to avoid passing on conditions like that. There are some surgical issues that we deal with. So a lot of the reproductive surgery, fibroids, polyps, endometriosis, things like that. I don't do a lot of surgery myself these days because there's plenty of people who are good at that. But sometimes trying to figure out if you should have surgery or where does it fit into your story is something. And so I often advise on that and then try to find the right person to help you with that procedure. So that's something that we often do in conjunction with other surgical specialists. More and more our medical system is getting specialized, and so it's hard to go to sort of one person who does everything. But I think getting a clear pathway is always a good thing. And then we deal with people that are dealing with cancers that are going to result in fertility limiting situations. So many times people with breast cancer or lymphomas, or people who are going to undergo chemotherapy who need to preserve eggs or sperm prior. And then I'd say the last thing is sort of just general advice on reproduction. So sometimes it's hard to get straight answers on this. There's lots of unhelpful advice that people will give you. And then there's lots of information online, and it's hard to figure out what's useful and what's not. And especially in this day and age, it's hard to kind of just get in with your regular gynecologist or primary care doctor, and they may not be kind of fully versed in these topics. And so even if you're not sure if you need to do anything, I'm always happy to meet with people and just kind of talk through what makes sense for them. The question of when to come is also an important one. So I think if you said, hey, my partner and I are going to try to get pregnant, you don't necessarily need to come see me right away. A lot of people get pregnant without our help. And that's, the beauty of our human reproductive system is lots of people do this without any help. But for people who are starting to struggle, that's when it is important that you connect with the right providers. And I generally say, there are some time-based approaches to this where they say, okay, well, if you're under 35, you should try for a year before you talk to somebody, or if you're over 35, maybe 6 months. But I think when it's starting to stress you out and if you have some other concerns, like you're not having regular ovulation, or you're concerned about other aspects of your reproduction, it's never wrong to come and see someone like me. Even if we're not going to do anything right away, just to sort of talk through a game plan. I think sometimes that's the hardest part, is not really knowing where this is going. And so for people who, even if you are young and healthy and you've been trying for 6 or 7 months and you're like, look, this just feels weird, all my other friends are pregnant, it just coming in and sort of saying, hey, am I in the right place? And we may not say, hey, you need to do a procedure tomorrow, but just kind of getting a game plan of like, okay, what happens if I get to a year and or a few more months go by and it doesn't happen. You can also start with local providers. So again, we're in one location, and Maine is obviously a big state, and parts of New Hampshire, obviously. So people can start working with their local primary care doctors or gynecologists, and I think their job in general is to sort of get you started, but there will be limits to how far they can take you. And so figuring that out is an important conversation. And if you're like, this isn't working for me, you can always ask to be referred, or even just make a referral to us yourselves. You don't need to go through another doctor to get to me. So we're always happy to see people if they're, in a situation that doesn't seem to be working for them. My last sort of general topic is sort of what to expect when you come to see me. And the first visit is generally an hour, which is a luxurious amount of time in the medical world, right? So normally when you're seeing your regular doctors, it's a quick 15 minutes and you're kind of in and out and not really having a lot of time. So we have the luxury of spending a good amount of time so that you can really explain your whole story. I mean, sometimes people have been working on these things for, a year or more and have a bunch of testing. And so we want time to go through your information and go through your testing and make sure that everything makes sense and that we hear everything you're saying. And I really want it to be as comfortable an encounter as possible. So I always tell people, like, you don't have to take any of your clothes off in the first visit. It's you're going to sit in my office in a normal chair. We're not like in a awkward, doctor space with like an exam or models of pelvises around. And so, you can bring your partner. So if it's male or female, or if you're single, it has to be a comfortable experience for everybody. And, it's a lot like this. I just talk to people and I try not to be super doctory about it. I don't want it to be so formal that everybody's uncomfortable. So, some of these topics are uncomfortable. We're talking about sex and sperm and vaginas, but at the same time, I hope that doesn't get us kicked off Facebook for saying that. But that's what we're, that's what we're talking about. And so I want everybody to feel good about that. And yeah, so it's, we have been doing Zoom a lot this year. We were in person for the end of 2021. We went back to Zoom for January and February. We're currently planning to go back to in-person visits in March. I'm very comfortable with Zoom or in person. And I think if you live way far away in Maine and you're like, I don't feel like driving 5 hours to go see Dr. Lannon for a conversation, like, we're happy to help kind of set up Zoom stuff and figure out if that works. So I think I'm hoping that will always be available, particularly for people that are coming from a distance, or if you and your spouse are both working and it's hard to find a day that you can take off. Like, the medical system has just not been very accommodating for people in the past. And so I think Zoom's a great, any kind of telehealth has been a great addition for that. So I see lots of questions piling up. So I'm going to turn to some of these, and I will try to kind of group them together and not get too distracted. But if I don't get to your question, I will try as hard as I can, and we'll go from there. I got some questions ahead of time, so I'm going to start with those, and then I'll go to the rest of them. One of them was about dealing with the wait in this process. So, one of the things people talk about is sort of, there's just a lot of waiting for something to happen. And it can be really devastating for people to, for lack of a better word. We're not a society that's very good at sort of waiting for stuff to happen, and particularly when it's something that you want. And this is one of these things that you don't really have a lot of control over. So people, who are used to achieving things in their life by working harder and putting in more effort, it doesn't always reward you. And so it's difficult to get through, either waiting to see if you're pregnant, or waiting to see if you're, gonna need to do another treatment, or waiting for results of everything. I am not a therapist. I do not have advanced training in any kind of mental health, but it's, this is a great challenge that we deal with all the time. And I think, number one, I would say, if you are someone who is struggling with these things, there are really good mental health professionals that we work with. And it's not like you need somebody to ask how your childhood experiences relate to why you want to have a baby, but just, how do you deal with some of these things, like, waiting and expectations and all of that. And so that can be helpful. Also, just kind of, there are group experiences out there, and Zoom and all of those things have made those things a lot better, because you may be in a small community where you don't have access to a group, but now you can get online and do that. And RNE, or Resolve New England, is a great place to start for that. They have a lot of support materials and things. One of the things that I tell people, like, don't like use the waiting time as just you're treading water and nothing good is happening, right? So there's like time where you're not necessarily making forward progress, but it doesn't mean that you can't have any joy or happiness in the experience. And so, sometimes people have a miscarriage, right? They got pregnant, they have a miscarriage, and now it's going to take, 4 to 8 weeks for things to resolve. And, I say, well, look, obviously you have to like wait some time to start your new treatment, but use that time to do some things that you couldn't do when you were pregnant, right? So there's all these things that people are like not doing, drinking coffee or alcohol or sushi or whatever you like. Take some moments to be like, hey, we can do this stuff. Or, we weren't going to go on this trip because I was pregnant and COVID and it's going to be weird, but like maybe you can do some of that stuff now. So I think try to, find some positives in that downtime, and that's a helpful topic. There's a question here about partner-assisted reproduction. So I was alluding a little bit to this before. So this is a common situation where two women are trying to conceive, or it doesn't, could be a woman and a trans person or somebody who doesn't have sperm, and you're considering one person is going to give the eggs to the situation, and then it gets mixed with sperm and you make an embryo, and then the other partner carries the pregnancy. And this is an option for some couples. And I always tell my lesbian couples, you're sort of blessed and cursed by having 4 ovaries and 2 uteruses in your relationship. It creates a lot of situations that other straight couples don't have, but just because you have the option doesn't mean you have to take it. And so I think it's important for every couple, but particularly same-sex couples, to like be really clear with each other at the beginning, sort of who wants to do what and what are they willing to do. So some people say, hey, look, I'm never going to carry a baby, or some people say, look, I really want to carry a baby, or we both want to use our eggs, or we both don't want to use our eggs. And I think especially when you have a conversation with me about it, like I want to hear all the things that you're thinking so that we can kind of make a plan that makes sense for you, because when you do have some of those different options, how you set things up makes a difference. And so so that's a sort of specialized circumstance, but it's something that we deal with a lot, and can obviously guide everybody through that. I got a question about cost, big topic, and sort of the most important part of most of what we do. Most things in healthcare, you go and you have insurance, or even if you don't have insurance, there's ways to sort of help cover the cost of things. Infertility, for a variety of somewhat annoying reasons, has been sort of carved out of the traditional healthcare system. And so people insurance companies say, well, it's not a requirement that people get pregnant, or it's not part of, everyday healthcare. So, it's just a luxury that people have to pay for. And that kind of sucks for a lot of people. That's my personal belief, but I think, in general, it's sort of disrespectful to people who are really suffering with, something that is an important health risk and associated with a lot of other, things that we consider diseases in our normal healthcare. So, so we are working on that. And if the state passes this law, someone asked the question of what does it mean if this gets passed? Mostly it's going to mean that many more people will get access. And so we saw this happen in New Hampshire. Like right away, all of the teachers in New Hampshire got coverage for infertility, which is massive. Like, when I look at my patients, it's like so many teachers and nurses are struggling with infertility, and it's a lot of the jobs that reproductive age women do, and it's a huge bummer that that a disproportionate cost of this falls onto those people who are already working in jobs where they're often not paid appropriately for the amount of work they're doing. So it's access will be huge. For like, what are we going to do personally? Right now, we're the only IVF center in Maine. If we have more volume and more people, like, we can expand. So we're already sort of planning to do that and sort of kind of following this bill, but we may add another doctor, we may open up other sites, things that, right now we're sort of limited in terms of what we can do, because we have enough to kind of keep up with the volume that we have. But if it gets bigger, then we can do that. So in New Hampshire, for example, I was seeing patients in Portsmouth, New Hampshire, this bill passed and we actually built an IVF center in Bedford, New Hampshire to deal with the rest of the state, and put 2 other doctors there. And so we have, you know, the ability to cover. So something like that would, I think, hopefully expand opportunities. You know, I think we do a great job at what we do, but not everybody loves us. And, you know, having competition in the marketplace always feels better for people, or at least choice. So, you know, I think that's hopefully what will, you know, start to happen. It can take a few, you know, it can take several years for that to all unfold, but, you know, I think it will be good. One thing we know is that like self-employed or self-insured employers, like a big employer like Maine Health, they don't have to follow these mandates. So it gets a little tricky because they're a huge employer, and they could be like, oh, that's, you know, that's the state applies to small businesses, but not to us. We manage our own healthcare. But as we've seen in New Hampshire, some of the hospital systems are sort of going along with the general regulations of the state, because you know, once it's sort of true in the general part of the state, then it sort of has to cover across other employers, and you know, people can sort of vote with their feet and say, well, I'm going to go work at this other place that I can get benefits, and so so I think that will be good in the long run. This was a really long-winded answer to the cost question. So basic costs, you know, we want to be really respectful of the fact that this is expensive, and I don't really want people to spend money on talking to me or doing tests that aren't helpful. So in every conversation, we really figure out, you know, what is your insurance? If you have insurance, or if you don't, you know, what's covered, what's not covered. We will credit back whatever you pay for your, if you had to pay to have a conversation with me as an initial consultation, we typically credit that back for towards future treatment if you need it. You know, we're very specific. I don't make everybody redo all of their tests that they've done. So if you have tests and we can get copies of them, then we'll just use what, you know, if they're, you know, up to date and good. Procedures can range. So like an IUI procedure, intrauterine insemination, costs around $500 in a month. That can be, you know, pretty low tech. Complicated IVF cycles where we're testing embryos and things like that can get into the, you know, $20,000+. Using egg donors can get into the $30,000 to $50,000. Using gestational carriers can get up into the $100,000+. So, you know, each of those things has a really specific, you know, application for everybody. And, you know, not everybody needs to do the most expensive things. So we often, you know, sort of, as I said, have a conversation about budget. I have a financial coordinator who works with me and helps to understand, you know, where you're at. We do a lot of income-based adjustments. So we try to help kind of sliding scale our fees so that, you know, it's accessible to a lot of people. We do discounts for discounts for people who are veterans and military service. So you know, I think I'm very upfront about it in all my consultations. We talk about what things cost, and we have that conversation. And I don't want to be coy about it, but I think you know, that's a big part of what we do, and making sure that what we do is accessible. Now, you know, it is too expensive. That is just an unfortunate reality of the whole process, and it's a little bit part of how our healthcare system works, right? Like medications are super expensive. You know, procedures that you have like ultrasounds and blood tests are, you know, they're not individually expensive, but if you do a lot of them in a month, it can all add up. And so these things add up. And for some people that, you know, I know for an absolute fact that there are many people on this call, and there are many people that I have talked to, and there are many people that will never talk to me because, you know, they can't afford this. And that is, you know, a lousy thing. And, you know, I am involved in a couple of organizations, and, you know, through this legislative stuff to really try to make these treatments accessible. Like, my financial interest in this is not relevant in any way. And, you know, you can hear some sort of sketchy things about how people think about insurance, but I would much rather have everybody, you know, have access to seeing me than, you know, have it be super expensive for one person to see me. So, you know, that's a factor to consider about costs. There was Mary Elizabeth wrote a long series of questions, and it's a really specific and complicated situation, but about one of the topics that I asked about, which is, or talked about with people having recessive mutations. And we do have the ability to work with outside genetics companies and develop probes to help test an embryo for genetic disorders. We have had success lobbying insurance companies to help pay for some of those genetic tests for embryos. Even they don't always pay for the IVF part, but they may pay for the testing of an embryo because they have some vested interest in that. And I think you had a lot of specific questions in here, and I think it probably makes sense just to sort of set up a consultation, and we can kind of run through all of that. And but I do think that all of your all of your topics are things that we can handle, and I think it makes sense to at least set up a preliminary conversation. Let's see, I'm going to go through here's a question. It says, 2 chicks here, me 42, her 37. Who's the mama carrying the babes with the best chance? Haha. So age is not a huge impact on who carries a pregnancy. Again, mostly it's sort of physical health. So if you're a healthy 42-year-old, then it doesn't really matter how old you are. The age of the eggs matters. So 42 versus 37, I would pick the eggs from a 37-year-old, but either of you could carry the pregnancy, successfully. And again, that's part of sort of the conversation of what makes the most sense for everybody. And some of it is who's willing and who wants to do stuff, and then there's some times where it makes more sense for somebody to carry because of things. Let's see. There is a question here about if you are 43 and going through pre-menopause, can you still do IVF treatment? Sometimes, generally the success rates for IVF are very dependent on the age of the eggs. And so as we get into the 40s, the IVF success rates start to not be great. It's a little depressing, but it sort of tracks the way that natural reproduction works in humans. And so our success rates drop down, into the kind of 5 to 10% range after 42, and then at 43, 44, it's in the sort of 3 to 5%, and then by 45, it's pretty low. A lot of times we talk about using egg donors in this situation, and egg donors are women who are usually in their 20s and they want to donate their eggs to somebody, and there's kind of egg banks now, like the way there have been sperm banks, so women can just donate their eggs and it doesn't have to be specifically targeted to somebody. This is a really tricky topic, and it's very easy to do medically, but personally it's a huge decision. But it's a really successful way to help a lot of people who otherwise can't get pregnant, and a lot of people who are pregnant in their middle 40s are doing this and you don't even know about it, right? So certainly all the celebrities who are getting pregnant in their late 40s are using egg donors. There's no way to buy better eggs or buy better reproductive chances, even with all the resources and doctors in the world. So it's unfortunate that a lot of people don't sort of admit that they're using egg donors, but we know all their doctors and they're using egg donors. So that's a really, I think a lot of people who think, oh, I'm too old to get pregnant, or I can't do this, again, it's mostly the age of the eggs. And so, we will work with people up to the age of 50 using egg donors. That's a way to kind of overcome some of the issues related with age. Interesting question. What percentage of your clients are vegan? What percentage eat whole foods, natural foods? Really, I do not know the answer to that. We have done we have some nutritionists on staff, and we're working with a nutrition group. A lot of people who are struggling with weight have problems with fertility. So, that's a big topic. And, humans get pregnant at lots of different weights. There are reality shows about this. So clearly, you don't have to be an ideal body weight to get pregnant. I will never sort of shame people about their weight. I think a lot of IVF centers are really kind of rough about this, and they're like, oh, if your body mass is over 35, we won't treat you, or you have to lose weight beforehand. And I think obviously there's the ideal world, and then there's reality. And if people could just lose 50 pounds and then do whatever they wanted, that would be great, but you probably would have done that already. So we have kind of information about what the impacts are of weight, we work with people of lots of different weights to sort of figure out a game plan. And so that's important. Specifically for vegan and vegetarian, we do ask people about sort of some dietary things related to gluten. So that's a kind of a big topic, but I'm not sure I know the specific answer to that, but I could certainly try to investigate. Diet and fertility is a hot topic, and what people eat and what its impact on their health is. And that's true of just diet and nutrition in general. We all probably have heard of people doing Whole30s or trying to cut out gluten and sugar. And to some extent, I think those things can make a difference, but not for everybody. And I think you always have to reality check a lot of these things by saying, okay, well, let's go to your local grocery store and look at all the people with babies, and they're not eating good food always. So you don't have to be perfectly healthy to get pregnant, but if you're not getting pregnant, then sometimes those lifestyle things are important. So cutting down on your vices like smoking and smoking absolutely is an impact on pregnancy. And a generation ago, everybody smoked during pregnancy, and it was kind of encouraged. So clearly people have figured this out. But at the same time, if you are not getting pregnant, smoking is one of the things that's very easy to cut out. Alcohol, again, it has to be somewhat in moderation. I don't think, if you cut out things that you like, then you just get grouchy and, you start craving those things. So I generally tell people to find a happy medium, but there's one. Is it okay to have a drink or two during the 2-week wait? So I think, you have to sort of find a balance of what makes sense to you. I think, there's some new guidelines on alcohol use in pregnancy, and we used to sort of say, a little bit is fine, but now there's sort of the new guidance is there's no safe amount of alcohol in pregnancy. My wife drank a lot of beer in pregnancy, so I can't really, I'm sorry if she's listening, but I know she's not. But you have to sort of you choose your battles on all of this. And during pregnancy, I don't think anybody will sort of say, oh, it's safe to drink alcohol, but at a certain point you can make some of those decisions. But when you're almost pregnant, or could potentially be pregnant, it's probably not a huge thing. So think about, why am I drinking? Am I just doing this because I feel like I need to do something, or could you do something else that might fill that void? But I think a lot of people sort of abstain really hard for those few weeks, and then when they get their period, they drink a bottle of wine, and that's probably worse than if you just sort of had a little bit here and there when you wanted to. Let's see. My husband keeps thinking it can still happen naturally for us. I keep telling him I think we need treatment. Is it more likely that I will need treatment at age 38? So yeah, this is a tough question, and men and women do not think about these things the same way. And I'm not a relationship counselor, but I spend a lot of my time sort of almost having two conversations in every consultation. I sort of have one conversation, and it's not always men and women, right? Sometimes it's two people with different opinions, but in a lot of heterosexual couples, you sort of have two people that are not on the same page. And most of the patients that I see after having tried for a year to get pregnant are not in a great place with their relationship. There's a lot of sexual dysfunction, right? So it started out fun and you sort of had sex when you wanted and it was great. And then as it stopped happening, as like more and more months went by where it didn't work, like people start getting more, serious about it, and they're peeing on sticks, and they're like, this is the moment we have to have sex. And then it suddenly goes from like, a thing that you like to do to like almost like a chore. That's super draining over a while. And then, people start having performance issues. A lot of men have start sort of getting anxiety, and right, you like leave a ovulation strip on the sink, right, and suddenly they're like having PTSD, and they can't get, there's like erectile dysfunction or anything like that. So I think it is really important that you maintain communication with each other during this process, and like specifically, how you feel about it. And again, I'm not a skilled relationships counselor, but I think the couples that sort of get through this the best are the ones that are sort of honest with each other about the process. And, sometimes you might say, hey, well, I think we need to go see somebody about treatment, and your partner's like, well, that's going to be $20,000 and I don't want to, get involved in all that kind of stuff. And I think, it's not always expensive. It's not always terrible. But I think being honest with each other throughout the process and listening, right? So men aren't always the best listeners when, again, I'm sort of generalizing, but, trying to really sort of make sure that everybody's, make sure you're being heard as well. And, sometimes you're just sort of at an impasse, and it's not going to be great. I talked to somebody today who's like, I know I need IVF, but, my husband doesn't believe in it. And, I'm like, he wasn't on the call, so it's sort of tough, but I was like, well, what do you not believe in? Is it just that you don't want to spend money? Do you not want to have a kid? Is it like, there's a lot of things that, sort of, the action is not the same as what's actually, what people are saying is not really representing what their absolute fear is. So it's not like you don't believe in IVF, you just maybe don't want to have a kid, or you're worried about whatever. So I think confronting some of those things is helpful. There are groups for this, there are relationship counselors, all of those kind of things. Again, not easy road, and you're not going to be like, oh, well, all right, fine, let's not do IVF, but let's go to a couples counselor. Like, it's probably in the same vein of things that people don't want to do. So that's a tricky one. Question here about, my sister wants to donate her egg to me and use my husband's sperm with IVF. Is that possible? Yes, absolutely. We use a lot of known donors. So through a sister, or any genetic relationship. I mean, you can use someone who's not related to you, but any version of egg donation is possible. We always want to make sure that the donor makes sense, right? So like, if you're 43 and your sister's 40, then she's probably not the best egg donor, even though she's a little bit younger. Like 40 is not a great age. So, there are people who have, younger siblings or step siblings or something like that. And, you kind of want your donor to be in the 20s and not much past 30, ideally. What is the timeline for IVF? IVF cycles generally take place over kind of 2 or 3 months, and it's not exactly months, it's sort of menstrual cycles, which aren't always a full month, but there's usually a part where we're giving people a short moment to kind of what we call down regulate their cycle. So we kind of take over control of the ovulation process, usually using a short course of birth control pills or some estrogen pills. Then we kind of mimic the normal menstrual cycle. So from period to ovulation is usually a 2-week window, and we give all the stimulation and monitoring and everything that happens during that time frame. Eggs and embryos are made for 5 days after they come out of you. And then in a traditional cycle, we just put an embryo back into you. There's some like testing now where you can test embryos for their chromosomes and freeze them, and then do a transfer in the next month. So it can be kind of a 2-month thing. There's a little bit of getting ready, and that's part of it. So again, it's people live their life in these sort of really painful monthly increments. And I sort of tell people, it's like you have like a stack of Post-it notes, and each month you're like peeling off a note, and it feels like you're just taking a little piece of your soul every month. You can't do that forever. So, our one of my goals is to just sort of say, okay, well, let's lay out the timeline here. And, it's not that time is the most important thing. It's just sort of like the plan, right? So an IVF cycle might take 2 or 3 months, which sounds like a long time, but like, when you're in it, we're like, okay, we're accomplishing this thing and we're going to see where we are at the end of those 3 months. And if it works, great. And if it doesn't, then we have to redirect. And, I think it's not the same as sort of feeling like, month after month is slipping away without any kind of game plan. So I always want to have like, here's what we're doing now. And if this works, here's what we're going to do. And if it doesn't work, here's what we're going to do. And so a lot of my role in this is just helping people come up with a plan that they can follow. Hi, Jillian. One of my former patients had twins. That's lovely. Nice to hear from you. Lots of time went by, 10 years for our relationship before this worked. That's another thing, a really interesting point. So, there are people who, I meet very early in this process, and I have had people that I've been with for 8 to 10 years, and they've struggled through all different kinds of things, but and it hasn't been every day for 10 years, but things kind of come and go and new opportunities present. And I think if you are committed, and that's not sort of a judgment, but just a sort of statement of fact, which is to say, like, people will persevere through any number of things, and this stuff can happen, and it may not happen exactly how you want it. You might have to use an egg donor, you might have to have somebody carry a baby for you, but and there's lots of dollars and heartache and all of that associated with that, but many people can overcome some really difficult odds. And you hear those stories and you're like, oh my gosh, I cannot sign up to do this for 10 years. But most people kind of come in, we have like a 6-month relationship, and then they're walking away pregnant. So it's not always like a big drawn out thing where you're doing multiple rounds of IVF. When you, particularly when you're on some of these forums, you hear from a lot of people that have struggled. And so you don't always hear from the people that kind of came and went and everything worked really smoothly. And that's a big portion of our patients. So, one of my roles in this whole process is to sort of help give you perspective, not let you get sort of sucked into this process where you're just doing it over and over again and there's no clear end in sight. So, I always tell patients I always promise to give people like honest answers about what they are up against. And, if it's not working or if it's not going to work, I'm going to tell you that. I'm not going to say, oh, maybe let's try again. And sometimes we don't know and we have to sort of make a guess, but there are times where we're like, look, this is not happening, and we have to choose a different pathway here. So Sam is one of our patients who has an IVF cycle coming soon. That's exciting. So, we have people at all different phases of the process kind of going through, and, there's a startup and, and you're in it, and then you're sort of seeing where it went. Do you have a lot of experience with PCOS and trying to conceive? Yeah, PCOS is probably the most common like reproductive issue we see. Polycystic ovary syndrome is, pretty pervasive in our society. It's not a disease, but it's sort of a cluster of symptoms. And many people who have PCOS struggle to get pregnant. They struggle with weight. They struggle with ovulation, and some other things. And so we work with people. I don't generally manage people who just have PCOS who aren't trying to get pregnant, but and there are some good resources for that. But I typically work with people who have PCOS and are trying to get pregnant, and we have a lot of success. It's a fairly can be a really simple pathway for people with PCOS, where all we need to do is kind of get you to ovulate, and then you can try to get pregnant like other people, and that works for many people. Sometimes we need to get you to ovulate, and then it turns out there are other things that are preventing you from getting pregnant, and then you kind of go through more of the fertility stuff. But a lot of people with like simple medication and a little bit of testing, we can figure out how to get you to ovulate, and it can be very effective. Let's see. How common is it that no embryo reaches day 5 despite high number of fertilized eggs? Yeah, really, this is a kind of very specific IVF question. So, many times we go through IVF, we're trying to get a lot of eggs, right? So a lot generally means something like 10 to 15 eggs. In the early days of IVF, we were like really inefficient. And so we would try to get, 30 or 40 eggs out of people, but that just sort of created a lot of discomfort and people didn't really necessarily do well. There's a point at which more eggs doesn't work out. So people are always like, how many eggs do I need? And like, again, in our sort of like first world mindset, we're like, more is better, right? So if you get 25 eggs, that feels better than if you got 15 eggs. But generally, the more eggs you get after about egg number, 16 or so, those eggs don't turn into babies. They just sort of don't fertilize or they don't grow well. So that like things just drop off more quickly. So we always try to get, as many eggs that are in the sort of sweet spot, like in terms of maturity and size, to a certain point. And once we get those eggs, then we put them together with sperm and let them grow. And the reason that we have to get a lot of eggs is because a lot of those eggs and sperm aren't going to turn into embryos. So over a 5-day period, you may drop from 15 eggs down to 3 or 4 or 5 embryos. And so at each step along the way, there's sort of a drop off. Now, sometimes we put all the eggs and sperm together and none of the embryos grow well. And we're like, whoa, what happened here? This may be, one of the reasons that you are not getting pregnant in the first place, right? So like IVF can solve lots of things, but if your eggs aren't good or your sperm aren't good, and that's sort of, I'm not saying that in an insensitive way, but just sort of in a general way, like if there's an issue with the egg or the sperm, we may reveal it. So I often tell people, for young people, IVF, generally will solve your problem right away, or it will reveal the problem that brought you there in the first place. So sometimes there are just issues with eggs and sperm. Sometimes there are issues with the protocol that got you there. So like you can go through a stimulated cycle and be perfectly healthy. And a lot of times people who are like really normal doing IVF don't always do as well, because they're like, my eggs worked fine when I was doing it, but now you're trying to do what my body does naturally and you're screwing it up. And so sometimes we can kind of make the situation worse by trying too hard. And so that's one of these things where you have to find the balance. And some people's eggs, some people you can do whatever you want and it's fine, and some people are really sensitive. So if you're a day off with the stimulation, or the dosing isn't quite right, or you didn't get quite the right blend, then the eggs don't behave well. I talk a lot about eggs. I mean, the sperm are also a part of this, but the sperm, we're not really controlling how much the sperm enter the equation. Once the embryos get made and they're put into an incubator, there's like what's called embryo culture, and there's a system for that, and every lab sort of follows similar principles, but some are different. And I think I'm very confident in our lab technique. We use the same exact setup and material that we use in our Boston office, and that's true of all of the Boston IVF centers. And we've been doing this for over 35 years, so we have spent a lot of time and energy perfecting these things, and we constantly are trying to improve what we're doing. So but sometimes things don't work in one place and then you go somewhere else and it works better. And there may be some subtle things. It's kind of like wine or bread or whatever, where the water and the materials that are going into these things can be different. And not to make it seem that magical and elusive, but there's some times where just you get lucky and it works better in one place or another. Sometimes people have done IVF in a bunch of times in other center and they come see us, we do it, and they get pregnant right away, and we're like, I don't know what we did, but great, I'm glad it worked. And sometimes like we do a bunch of stuff and it doesn't work, and then somebody goes somewhere else and it works. And same thing. Like my goal is not that you suffer through stuff with us or it doesn't work. I mean, we just want you to be successful and done with all of this so you can get on. Like that's your goal and mine should be the same at the end of this. So my ego is not a part of this story. Let's see, is 33 too old for an egg donor? Not necessarily. Again, a good 33-year-old, if they have a good number of eggs, can be okay. Again, having somebody that if it's your sibling or whatever, you kind of make some trade-offs there, right? So like a 22-year-old that you don't know and a 33-year-old that you do know, like, there may be some advantages to doing that. So, we see people, do different things. And anytime we're going to use an egg donor, we do a full evaluation on the person and make sure that they kind of, physically and mentally and psychologically, it makes sense. But yeah, that's a good question. Question from Cindy: after 4 miscarriages in a row, what do you suggest for us? So recurrent miscarriage, I didn't even put on my list, but it's a big oversight. But that is a group of people that we work with, right? So, the definition of kind of infertility is people that aren't successfully pregnant, and getting pregnant and having a miscarriage is not a successful pregnancy for us. So, it's sort of sometimes two sides of the same coin, right? So not getting pregnant or getting pregnant a lot can, be devastating in their own way. And recurrent miscarriage is a really tough group of people to work with. We have some tests that we can do to help try to understand if there's any knowable or treatable cause of miscarriage, but we often don't find an obvious one. There is some amount of miscarriage that is normal in the world, and it sort of sucks, but it's like how human reproduction works, right? So there is a very good editing process, for lack of a better word, in our reproductive system that prevents abnormal pregnancies from going forward. So a lot of miscarriages are just, hey, this embryo wasn't destined to be. As humans, we don't get pregnant very often, but when we do get pregnant, we have generally pretty healthy children. And so that is a sort of thing that you have to separate out. Well, what is normal miscarriage from what is, where it's a problem, or, recurring miscarriage. And some of it is dependent on age, and some of it's dependent on your story. So we always do kind of a full evaluation. Cindy, your story I know is a tough one, and we try a variety of different things. There's some stuff that we have tested that we know doesn't work, and there is stuff that we have tried and people get pregnant and we don't think it works, but it seems to. So there's a point where like the science and the art sort of blend, and we're like, okay, well, we don't have a good answer, but let's try some stuff. There's a whole kind of field of what's called reproductive immunology out there, and it's in early stages. So there's a lot of kind of partial information, and you can sort of read some of these things online about people who are doing some of this testing, but it's there's a lot of stuff that we're still trying to figure out with miscarriage. And the best thing that we can do is sort of go through your story, go through the testing. Sometimes it's just sort of trial and error, and trying to figure out what we can do to help. And I had a patient, Allison, who she has had multiple miscarriages, and we just tried a bunch of stuff, and I think she's in her maybe almost 20 weeks pregnant now. And we did some things that I'm like, I don't know what worked or why it worked, but like, let's not ask too many questions at this point. And I know that doesn't sound like great medicine, but I also think at a certain point you have to kind of take a chance on people. Oh, here's an easy question. Is Dr. Lannon in Maine or Boston or both? So I am sort of exclusively in Maine and in New Hampshire. So I see patients in Portsmouth, New Hampshire, out of Harbor Women's Health. We have a office that's sort of in the Bedford area of New Hampshire. So for people that are sort of more oriented to central and Western New Hampshire, that's over there. But I see people kind of on the border of New Hampshire and up into all of Maine, basically. So I am generally in the Maine office every day. On Fridays, I'm in the Portsmouth office most Fridays. The last couple of months I've been doing Zoom, so it's sort of chaotic, but we'll go back to that format. And yeah, I don't see people in Boston. I did all my training there, and I have had plenty of time in Boston, but I am now in the Maine office. Oh, there's another one. Does Dr. Lannon see out of Portland or Portsmouth? So yeah, so I am in Portsmouth. And I actually live near Portsmouth, so I have to, full disclosure, I am not a Maine citizen, but I can see Maine from my house, so I feel like that counts. But I grew up in Seacoast, New Hampshire, so I still live over there. And yeah, so I see people there on Fridays, and we'll go back to having that. I see people over at the Harbor Women's Health, which is one of the big GYN groups in Portsmouth, is where I see people. So it's just me there. We don't really have a lot of like procedure stuff set up there. We do monitoring there, so we can do blood tests and ultrasounds and things like that, but mostly it's consultation. And then you know, for the procedures, everything is based out of our main office. There are people who live kind of in the middle ranges here, so you're closer, you know, you're sort of like, maybe you live near Portsmouth, but you work near Bedford, or I have people who kind of come see me who live in Newburyport, which is sort of like in between everything, and they come to see me in Portsmouth because they maybe work there. So one of the nice things about Boston IVF is that we have kind of locations a lot of different places. And people from Northern Maine, I know you can tell me that we don't have a lot of places in Northern Maine. So that is, you know, I apologize. We are not servicing as much as we should in that area. But, you know, if you live in sort of some of these in-between places, we can use some of these other locations. So like if you live in Portsmouth, you can do all your monitoring in Portsmouth, or we have a monitoring site in Dover, New Hampshire, and that allows you to not keep coming back and forth to Portland. The procedures like the IVF, taking out your eggs and putting in embryos, that happens in the South Portland office, but we try to, you know, respect people's time and not have you going all over the place. Here's a question. Do you recommend egg freezing after 35? So egg freezing is a, you know, moving topic. There's lots to talk about, but you know, generally I would say we will, you know, if you have good egg reserve, you can freeze eggs after 35. I would say generally up to about 37, 38 is where you would want to make a decision on egg freezing, but overall, a little bit the sooner the better for egg freezing. Let's see, will you still have a practice or will you still have a practice or office in Bangor? So Dr. Alper is one of my partners. He's one of the founding partners of Boston IVF, and he sees patients in our Waltham, Massachusetts office, but he has had a 30-year practice in Bangor and is continuing to go up there. And I do not know of any plans that we will not be doing that. So I know there's always sort of change in the political landscape of different doctors' offices, but you know, on those sorts of places, we're just using the space to see people. So we're not necessarily connected if you know, if one office closes or we can't, you know, use that space, we'll find another one to keep going. But that is that's a goal. Someone, thanking Dr. Lannon for my now 3-year-old son. Hi, Melissa, thanks for that. And she has a question about endometriosis and what are your thoughts on surgery? Yeah, it's there are people who are really good at specializing. She asked a question about Dr. Martin Robbins, who is one of the people who does a lot of endometriosis surgery in Portland, and I think is, you know, sort of that's his area of specialty, and he's really good at that. And I would say certainly, you know, worth a consultation. Not everybody who has endometriosis needs to have surgery, so it's sort of one of those things, again, along the lines of like, when do I need to meet with a surgeon? You know, that's a conversation we can often have and try to figure it out. But yeah, happy to kind of talk more about that. We're down to the last couple of minutes here, and I feel like I did an okay job on these questions, but thank you so much for all of these questions. Let me see if there's any other quick ones to answer. Lots of former patients. Thank you so much. Okay. Some thank yous. Hi, Nicole, and Jess and Amanda. I feel like I'm a Peloton person giving shout outs. Yeah, so I think I'll pause here, and I really appreciate all of you participating. I want to be respectful of people's time and everything. So, but we'll do this again. We have done this live in years past, and we often find like a brewery or somewhere in Greater Portland or you know, up somewhere else in Maine to get together, and we're happy to do that again. But I think this is a great format to get a lot of people who you know, maybe from, you know, don't have easy access to driving to do this. So I think, again, part of our goal is to just get outreach and make sure people have time to sort of understand what we're doing and what's out there. And, you know, again, my intent is not to like convince you to come and have a conversation with me about things, but I think at the same time, you know, if it's something that makes sense to you, it's not going to be a scary thing, and I'm happy to go through it all and try to figure out where to go. So thanks everybody for joining, and have a good night. This is the last that we're going to see 50 degrees for a while in Maine. So I think we're back to low digits tomorrow and through the weekend. So everybody stay warm and dry, and spring will be here soon enough. So great. Okay. Thank you very much.